Hello, everyone. My name is Grace Dennis, and I'm happy to welcome you to the 6th annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department and the Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions for our local regional healthcare providers about cannabis use and their patients. Our speakers come from a wide variety of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for one social work continuing education clock hour, one related McBath credit hour, and one credit hour of CME. If you are requesting any of these continuing education credits, please be sure to stay until the end of the webinar to fill out our post-webinar evaluation survey. Please be sure to include your name and email address to ensure that you receive certification for your attendance. This webinar is being recorded. The webinar recording and presentation slides will be available on our website at washtenaw.org/marijuana in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function at the bottom of your screen. I am pleased to introduce today's speaker, Dr. Karen Osilla. Dr. Osilla is an associate professor in psychiatry and behavioral sciences at Stanford and a licensed clinical psychologist. She conducts health services research with a focus on delivering substance use services to underserved population using innovative solutions that decrease health access disparities. Dr. Osilla has received funding from the National Institute on Drug Abuse, the National Institute on Alcohol Abuse and Alcoholism, and the Patient-Centered Outcomes Research Institute, and has published over 100 publications on this work. Dr. Osilla has been conducting addictions research since 2006 and has been involved in over a dozen clinical trials evaluating cognitive behavioral therapy, collaborative care, and motivational interviewing interventions. Please welcome Dr. Osilla, but before we go ahead and get started, if we could just continue the next slide, we have one item to read about the CMEs. None of the planners or speakers for this educational event have any relative financial relationships with ineligible companies to disclose. I am happy to now pass it over to Dr. Karen Osilla. Thank you so much for joining us.
Thanks, Grace. I really appreciate that nice introduction, and good afternoon, everyone. It's wonderful to see so many people interested in this motivational interviewing talk. I'm really excited to get to know you. So I've been doing motivational interviewing for the past 20 years. I first started in graduate school at the University of Washington. And my favorite part of MI is that it's very interactive, it's very engaging, and it's meant to be collaborative. So in that true style, today what I'm going to be doing is I'm going to be asking you different questions. I'm going to encourage you to take advantage of the chat. I put a little icebreaker over here for people to introduce themselves, tell us where you're coming in from. And throughout today, I'm going to encourage you to participate, because I want to make sure that you have a chance to really use the MI skills as we talk. It's one thing to listen about MI, but it's another thing to actually practice it. All right. So the title of my talk is really talking about practical strategies for empowering people to change. What I'm hoping to do today is really to leave you with 3 MI advances to use in your practice. And this is based on the last edition of the Motivational Interviewing book, which is in its 4th edition now. It just boggles my mind that a book is in its 4th edition. And the years of experience that I've been using MI for in my clinical practice. I am at Stanford right now, and I work in our addiction medicine clinic. So we see a lot of patients struggling with substance use, especially cannabis use. And so we'll kind of draw from those experiences today. So I mentioned that I did graduate school about 20 years ago at the University of Washington. And when I was there, I learned how to use motivational interviewing from my mentors, Alan Marlatt and Mary Larimer in Seattle. And I participated as a facilitator in this program called Basics. Basics is basically a brief program for college students who are busted on campus for drinking alcohol. So these are students who are forced and kind of mandated to come to our program to talk about their drinking. And as you imagine, a student that gets busted, gets in trouble, and is forced to come to a session, they come in with a lot of reservations. They come in with their arms crossed. They come in not wanting to be there. And the thing that they're going to expect you to say is to change your drinking, to stop drinking. It's getting you in trouble. And they're almost expecting that you're going to tell them what not to do. Basics is a unique approach because it uses motivational interviewing. It engages a student to talk about the reasons why they like to drink, and if they were to drink, how to do it in a safe way. And it's a wonderful program. And what boggles my mind is that using the motivational interviewing style with these students, it lets them open up. It helps them talk about the different pressures that they're experiencing, how they just want to fit in, how all their friends are doing it. And it gives them also feedback about norms to drinking and if people, what people around them are doing. And the research shows over about 20 studies is that students who take the basics program a year later will report reduced negative consequences related to drinking and reduced heavy drinking when you compare it to control conditions. So it's widely effective. And what boggles my mind is that about 90% of the students who participate in the basics will recommend the session to a friend. The truth of the matter is that when people are enjoying something like addiction, the last thing they want to hear is to not do it. People who are using substances do it for a lot of different reasons, one of which is pleasure. And to be told not to do it, why it's unhealthy to them, it almost produces this like reactive nature, right? They want to do it even more if someone tells them not to do it. And when we work with youth, we know this is very prominent. College students, I now have a 13-year-old, so I know firsthand that when you tell him to do something, he'll do the opposite. And it's almost like a natural reflex, right? Like when someone tells you something not to do, you do it anyways. So the first tip that I have for you all today is that we are not fixers. We are helpers. And the MI4 book talks a lot about this. And it talks about how when we tell people what to do, when we advise them what to do, when we do that, we're almost as if we're using an expert point of view. It says, let me tell you what you need to do. It is born out of concern and caring. All of us are providers. We want to naturally help someone. And when we see someone in pain, we want to give them tools. We want to give them advice so that they follow through or they're able to get on the mend. But when we are in that fix-it mode, when we just tell people what to do, their natural reaction, most of them, will be to not do it. And so in MI, we really talk about how we are helpers. What would you like to discuss? How do you want to get there? And the idea is to accompany people on their growth journeys. So someone comes in having heavy cannabis use. It's not telling them that they need to stop because their health labs show XYZ. It's tell me more about your use. I know you've been using for a long time and it sounds like you're having some concerns about it. Tell me what those are like for you. And it's reflecting back the things that they're saying so that they themselves can come back and talk about ways that they want to change instead of you telling them what you want them to change. I'm going to read this definition, and what I'd love for you to do is to write out words that kind of stand out to you as I'm reading the MI definition. So motivational interviewing is a particular way of talking with people about change and growth to strengthen their own motivation and change. Autonomy, I like that. Encouragement, I like that. Thanks, Amanda. The idea is to practice restraint. The focus in a person-centered approach is on your client and not yourself. Your job is to regulate your own emotions, to be modest with your own desire to fix things and provide solutions. You are not the only wise person, and as a helper, you are a guest in a person's world. So thank you for putting in the chat the words that kind of stand out to you. Empower is one that stands out to me too. REIC saying growing and motivate. Here's the deal. We are helping providers, and for us to practice restraint is hard because we see people in pain, and what we don't want is for them to be in pain. So we'll just tell them what to do. But in doing that, that sacrifices the amount of talk that the patient can have in terms of them empowering themselves to change. And so listening is a very powerful tool in MI so that you know what to strategically reflect back to them so that they can come back to you. Restraint is one of those words that when I read this in the MI4 book, I was like, oh boy, restraint is a very powerful word. As helpers, we are not the only experts in the person's world, and in fact, the person is the expert. So there are 4 phases to motivational interviewing, and the first one starts with engagement. The engagement phase is very, very important. This is the phase where we really aim to form a working relationship. And I will tell you that the most common barrier to people using motivational interviewing is them saying that they don't have enough time, that they have a whole panel of patients that they need to see in the day, and they only have however many minutes with them. And so they don't have time to talk with them. They don't have time to engage with them. But engagement only takes a couple of minutes, and it means the world of difference. When someone comes into your office for the first time, second time, maybe if you're lucky, the third time, they are testing you out. It's like the speed dating, right? Within a second, within a couple of seconds, they'll know whether you are a person that they want to talk more with. And engagement allows that to open up, to invite the patient to come in. Tell me how your summer is going. How is your day going? It's great to see you. Tell me what brings you in today. And you listen. And by listening and engaging, that builds the trust for the patient to talk about issues that they're concerned about talking about. Can I trust this person to talk about my weed use because I've been using for 20 years and I don't feel good about it? Can I trust this person to listen to, how I'm really struggling with trauma and that's why I'm using marijuana? Engagement is a way to walk with the patient together. I put this house icon on this slide to remind myself that when you go to a person's house, what's the most common thing you're supposed to do? What's the most common convention? When you are invited to somebody's house, what's the most common convention to do? You can just put it in the chat. Yeah, bring something to share, bring a gift, take something. But in order to do that, in order to share something with them, you need to know a little bit about them. You need to know a lot about them. You need to know whether or not they drink alcohol. You need to know whether or not sugar or sweets are something that they love to have. You need to know whether or not they get offended if you actually bring a side dish. You thank them, right? You thank them for coming in. You thank them for inviting you. Ask if shoes are inside. So it's a very considerate, tell me what's important to you. And that's what engagement is all about. Tell me what's important to you. Your job as a provider in engagement is to grab a value of them, grab what interests them, and then you know that you've engaged them. The second phase is focusing in. So figuring out with the patient what the target behavior is. You may have been referred a patient because of their cannabis use, but what really is important to them? Is it their health? Is it their mood? And by negotiating the goals, you might get to the crux of the issue, which might be cannabis. Evoking is my favorite phase aside from engagement in MI. And evoking is where you use your questions and your reflective statements to get them to talk about change. If a patient says something like, yeah, I've been using cannabis for 5 years and it's finally catching up to me. It's really messing up with my productivity. Tell me more about how it's messing up with your productivity. Oh, well, I'm not able to meet my deadlines. I go into work late. Tell me more about how that's affecting your life. And so you evoke the change talk from the patient so the patient could say more about why they want to change instead of you saying more about why they want to change. And then as you'll notice, planning is at the very end. The planning stage is at the very end, and this is where you talk about next steps. This is where you problem solve barriers, and this is where you might want to choose the next step in the change process. And I say this because planning is oftentimes at the forefront of what we do. It's almost the first phase. Oh, you've been using cannabis for 5 years. Let's talk about how to change that. What ideas do you have? But if we don't do the engagement, focusing and evoking in the very beginning, then we don't have reasons for why the patient wants to change their use. So here's the MI toolbox. It's in the acronym ORS, and many of you, I'm sure, have seen this before. Open-ended questions, and these are the ones that start with what, tell me, how, and why. And the reason why we want to do open-ended questions is because we want the patient to talk more, as opposed to closed-ended questions where they will say yes or no. So the what, tell me, hows, and whys are open-ended questions. Affirmations is a very is highly emphasized in the MI4 book. And in affirmations, what you want to do is really emphasize an enduring strength of the person, their value, an accomplishment, an effort. They call this the positives. So it's not just affirming them like, thank you for coming in today, but it's really like, I see that you're someone who really responds well when you have a goal. Like once you set your mind to something, you accomplish it. It's something enduring about the person. And the idea is to elicit the warm and fuzzies. It's to empower them, for them to help recognize the strengths that they have in themselves. It's more personal. Thanks, Shirley. Reflections are statements that repeat and rephrase what the person is saying. And we'll do some exercises on that. And then finally, summarizing, where you strategically collect and transition on to the next topic. So whenever someone is interested in considering a change in their behavior, they always experience this ambivalence moment. You think about New Year's resolutions. I need to go to the gym more. There will always be ambivalence to changing your behavior, some pros and cons. In the context of smoking, the ambivalence moment may be, I need to stop smoking, but smoking helps me relax. I get a lot of pleasure when I do smoke. I really connect with people who smoke. And the idea with MI is to get the patient to say more about the pros to changing versus the cons to changing. And so you really want to use your questions, your open-ended questions and your reflections to get the patient to talk more about change and less about the cons to changing, or what we call the sustained talk. And the research shows that it actually does really matter when people say change talk versus sustained talk. And what you do as providers really makes a difference. And so change talk is associated with reductions in substance use. Sustained talk, or language in opposition, the cons to changing, is associated with greater substance use and fewer readiness to change behaviors. And in the research, when you kind of compare change versus sustained talk, it's really the sustained talk that keeps clients at status quo. And you as providers directly influence them in the way that you phrase your questions and your reflections. So here's a little exercise for you. When someone comes to your office and says, I don't have a problem with weed, what are some of the questions that you ask them? They come into your office, they say, I don't have a problem with weed. What is your follow-up question? What do you ask? And if you don't mind, just put a couple of those in the chat. Tell me why you came in today. Good, tell me more about that. Okay, what are you here for? Good. Tell me more about it. What do you like about it? Nice, Joe. So these are great questions. You want to open up the invitation. You want to engage. You want them to say more about that. Tell me what you're hoping to talk about today. Great. What's your perspective? What symptoms are you here for? So the way we phrase your questions will dictate what happens next. So if you ask the question, tell me why you don't have a problem with weed, they're going to talk about why they don't have a problem with weed. If you ask, what do you like about weed? They will tell you all the things that they like about weed. And the direction that they talk about will predict whether or not change will happen. And so common questions that people will ask are, why do you feel that way? Tell me more about that. But you just got busted for smoking at school. Your parents say your use is getting worse. Your grades have dropped. And these types of questions, most of them are okay. Like we want to understand why they don't have a problem. But if you're in a time crunch and you've got 2 minutes left of your visit, you want to strategically phrase your question so that they don't talk about sustained talk next. And all of these questions get them talking more about sustained talk. They're valid questions, but again, if you're time limited, you want to strategically ask a question so they come back with change. So my tip number 2 is to guide the person to change talk. And here are some ideas of how to do that. So again, here's a statement. I don't have a problem with weed. I'm glad things are going well for you. What does having a problem mean to you? And here's my favorite question. How would you know if things weren't going well? This should say, what concerns you or others about your weed use? You might reflect. Being healthy and responsible are important to you. And then Amanda, you predicted my question. What would a problem look like? What could we look out for? So you might summarize something like, what I hear you saying is that you worked hard to keep your use under control. Things are going well for you and you're getting to school on time. You're able to use less when you want to. I wonder, I like this question, I wonder if we could chat about ways to continue preventing future problems. Okay, you and Matt get a good prize. So the idea, if you are in a time-limited situation, is to know that the way you phrase your questions can guide a person to change talk. So you guys tell me, here are 4 sentences. What I want you to do is I want you to read the 4 and put in 1 to 4, which of the statements you think have an element of change talk. So you can just put 1, 2, 3, or 4 in the chat. So the first one is, it's not like I smoke that much and that it's affecting me at school. The second one is, I got A's and B's and I stay on top of my work. It was just one party, but I'm glad I didn't get into trouble when the cops showed up. And the fourth one, I don't know why my parents are making such a big deal. Good. Oh, wonderful. So a resounding number 3 for change talk. And you know, number 2 hints at a little bit of change talk. It hints at a little bit of why that person might be interested in changing. You can tell that, grades and school is really important to this person. And so I highlighted number 2 in purple too, although I agree with you that number 3 is really where the change talk is. So the idea is, when you hear the change talk, you want to reinforce the heck out of it. You want to positively reinforce that. And so how you might do that is say something like, doing well in school is important to you, and you've worked hard to do well. Whenever you're able to understand something important about the patient, you want to reflect that. Doing well in school is important to you, because by doing that, the patient feels like you get them. And you've kind of waved a carrot in front of them about a reason why they might be interested in changing. Other ways to reinforce change talk in number 3 is, when the cops showed up, it was really scary. And by saying that, hopefully they'll continue on talking about how it was scary and how they don't want that to happen again. And then finally, number 3, you think things are going fine and there's nothing wrong with your use. What are things we might look out for if your use was causing problems? Okay, here's another one. 1, 2, or 3, where is the change talk? Number 1, smoking weed helps me fit in with my friends, but I'm lazier on the weekends now. All I want to do is stay in bed. I used to exercise a lot more and I miss it. Excellent. So I'm seeing some 1s and 3s. You guys got it. I'm lazier on the weekends now. I used to exercise a lot more and I miss it. Okay, so now we've identified the change talk. We've heard it. Now we want to have them talk more about that. Connecting with your friends is important to you, right? Grab the value, what's important to this person. But you're noticing that smoking weed is bringing you down. Your energy isn't what it used to be, and you're not working out as much. Smoking weed is getting in the way of you staying healthy. Grab those values and repeat back what those values are meaning to say. So Amanda, you say seeing number 2 can also be change talk. That sounds like it's a negative smoking about weed. All I want to do is stay in bed. So if we were to say, tell me more about that, the client might also continue on. My bed is so comfortable. You know, when I use, all I want to do is just be in there. And so it could go either way. Either they'll talk more about the joys of staying in bed or the cons to staying in bed. But when I stay in bed, I'm not able to get to work on time. So I can see that going both ways. Okay, I want to show a quick video on empathy by Brené Brown. This is probably one of my favorite videos. It's just a couple of minutes, but it gives an understanding and it demonstrates why empathy is so important. And if you could, if in the chat you cannot hear the audio, just let me know.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
I love this video. And then now every time I say at least, I think of it because I always do that. The idea with MI is connection. The idea is not to give it a fix-it response, to take someone out of the pain. The idea is connection. And it turns out that empathy from a provider perspective can be very reliably measured. And we do some of this research where we audio record sessions that are part of a research study. And there is coding mechanisms where we can measure the amount of MI in a provider session. We can tally the number of open-ended questions, we can tally the reflections, but we can also rate the amount of empathy that a coder feels that the provider is exhibiting. And it turns out that empathy, the amount of provider empathy that you have, predicts whether or not a client will drop out, whether or not a client will change. And this makes sense, right? When you think of the people that you meet, right away you can tell if it's a person that you want to continue talking with in the future. Same thing for your provider visits. Your patient is checking you out, whether or not they want to come back. And the amount of empathy that you have determines that. This video is Brene Brown, and you can find it on YouTube. If you just search Brene Brown empathy, it's a wonderful video. So empathy is not having the same experience or problem. It's not, let me tell you my story. It's not, I've experienced it. Now, I don't want to belittle lived experience and shared experience. I think it's very valuable. And I don't think it's an essential part of a therapeutic relationship. What I do think is part of what is essential is having empathy and being accurately able to understand the client's meaning and what they're wanting to, what they're trying to say, and reflecting back. And so you do this through reflections. Reflections are statements. They make a reasonable guess about what the client is trying to say. And there's a continuum. So on the left-hand side is a simple reflection, and on the right-hand side is a complex reflection. So going back to your school days, simple reflections are like It's plagiarizing what the person is trying to say. So if a client says, I don't have a problem with my weed, it's saying, you don't have a problem with your weed. It's just copying, it's mirroring what you want, what the patient is saying. So you don't want to do this a lot because it just sounds like you're a parrot. But when I first started using motivational interviewing, my supervisor told me, if you don't know what to say, instead of fixing it, just follow and kind of repeat back what you hear them saying. So a simple reflection is just repeating what they have to say. I don't have a problem. You don't have a problem with your weed. Now, if you can get to complex reflections, this is where really the magic happens. Because what will happen is the patient will continue on with the reflection that you say. And so a reflection that's complex paraphrases their words or reflects emotions and values. So in this example, the simple one is you don't have a problem with your weed, but you can complex it. You can say having a problem would mean that your use was getting out of control. And this is really where the magic happens. When you're able to put beautiful words on what you think the patient is trying to say, it really fosters connection. So where I say here, getting out of control, that might really resonate with the client and they might continue on with the conversation. Yeah, I never thought it would get this bad, but I can't even wake up without using anymore. And you talk about that. Another one is reflecting emotions and values. You're concerned, they're worried about your use. Being healthy and responsible are important to you. And so when we work with our teens and their teens are telling you that, you know, I'm only here because my parents are really upset with me about my weed use, you know, because I have to be here because of school. You're wondering why they're concerned about you. It's hard to see them so worried. You foster that connection. So now I'm going to ask you what you would say. So if a client were to come into your office and they were to say, I'm really depressed and nothing seems to be helping, what are some reflective statements that you would say? And just type in the chat what you would say. I'm really depressed and nothing seems to be helping. Good. How is this affecting you? Please tell me more. That sounds like a really frustrating and discouraging experience. Ooh, I like that. You've been trying to feel better for a while. Tell me more. Good. What has helped in the past? Tell me what's going on. Great. So we can respond in various questions and reflections. I hear you're saying you're depressed and nothing seems to be working. Tell me more about that. Ooh, you feel stuck and aren't sure what to do next. Fantastic. So again, the way we phrase our reflections or questions will predict what they will say next. So if I reflect in a simple reflection, nothing seems to be helping, it's very likely that they're going to continue on with the nothing theme. But if I ask a question like Dawn and say, what do you think would help you feel better? That would kind of reroute them and talk about what would help them feel better. Dorothy, I love that. It sounds like you feel sad and you feel stuck. That's very validating. And then they'll talk more about that. And then once they share more, then you can talk about what do you feel like is the next step. Okay, here's another one. No one understands my situation. It's just impossible. If you were to say a reflective statement, not a question, what would you say? Yeah, sounds like you feel very alone, isolating. It's a difficult time for you. You feel disconnected. Okay, can you explain to me what this means to you? Ooh, Sharita, I like that one. It sounds like you want to be heard. Do you all see how that pivot predicts what the patient will say next? Yes, I want to be heard. I want someone to not tell me what to do, but to understand that I'm using because blah, 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 blah. Okay, I hear that you want to be heard. Let's talk about how you can be heard today. Wonderful. Okay, here's the last one, and then I'm going to continue on. I don't want to use again. It would be awful. Really try to focus on the change talk here. What would you reflect in this situation? I don't want to use again. It would be awful. What's the enduring quality of this person that might be coming across in this statement? You see reasons, good. You're looking for a way out. That's very brave. How can we plan for your future? I love it. It sounds like you don't like how you feel when you use. Great. I also see commitment. I also see ready to change. You want to move forward with this part of your life. And I also see determination. You're determined not to go back to old ways. How might we do that? What might that look like? Wonderful. Thank you all for doing this. This is so fun. It is so hard to do this presentation on Zoom without seeing your pretty faces. And so the fact that you're putting these chats in just makes my day. Love it, Tori. It sounds like using is no longer an option you want to reach for. That's really beautiful. Thank you. Okay. In the handouts are some more statements for practice, but I want to make sure we get to the last tip too. The last tip is straightforward. Kind words go a long way. And I emphasize this a lot with my 10 and 13-year-old, that kind words really do go a long way. I mentioned earlier in the talk that MI4 really emphasizes affirmations now. They used to just call it affirmations, but now they've distinguished between simple and complex affirmations. And I mentioned before that these are really ones where you emphasize a value and enduring strength. And the idea is to really focus on their strength and their capacity for changing. Because what you want to do is you want to build their self-efficacy. The research shows that when people are changing their substance use, what predicts what if they will change is how much self-efficacy they have. In other words, how much confidence they have that in high-risk situations they won't use. And so you want to build their strengths as much as possible. And the idea with affirmations is you want to leave the I out. Affirmations are about the patient. And so you often begin them with you. You don't say, I see how determined you are. Because it's not about your recognition of them. It's you're really determined. I appreciate you coming in today. Instead of that, saying, it took a lot for you to come in today, you made it. It's leaving the I out to empower them that it's about them. I do research most of the time. 80% of my job is doing research, delivering substance use treatments to vulnerable populations, and a lot of it is using MI. And one of my particular projects, working with family members with opioid use disorder, the funder is just really on it. Like, they want weekly reports, monthly reports about how recruitment is doing. And in the heart of pandemic, recruitment was not going well. And the funder had a hard time with that. And for the first time in my life, in about 20 years, I just really struggled with that. Like, I felt like the constant reports and reporting and justification for our delays, I felt it personally, like I was doing a wrong job. I wasn't doing very well. And one of my staff members, my colleague, said to me, she said, of all the people I know, you're such a fighter. And when she said you're such a fighter, like, it just like cemented me. Like, I was just like, I am a fighter. It like just really like spurred me on. And so these affirmations, when people are able to draw out your strengths in moments where you are feeling defeated, and it's with someone that you trust, it means the world of difference. So simple affirmations could be saying something like, you handled that meeting well. It could be my colleague was in that meeting and she said something like that. I love it, but it's simple. And so a complex reflection is what she said to me. You've dealt with so much. You're such a fighter. And then when I heard that, I'm like, I am, and it built my self-efficacy. And that project is doing really well now, by the way, after the pandemic. With all the obstacles that you've overcome, and now this latest one, you just keep going. You're someone who is really determined, even when the going is rough. Notice all the yous, there's no I's in there. So for those of you who are interested in the 4th edition of MI, it's a fantastic book. All of Bill and Stephen's books are really great. But here are a couple of, or more than a couple, here are some unique parts of MI4 that I might highlight. So they really focus on words. MI is all about the words that you use. And so they focus on the words of helpers versus providers. They talk about empowerment. And instead of calling it the writing reflex, they call it the fixing reflex. They talk about ask, offer, ask, which I have a slide on coming up in a few. And they talk about 8 observable skills. They talk about this research where they again study these audio recordings of what therapist skills really predict patient behavioral change, and empathy is one of the core ones that do. And they talk about simple and complex affirmations, like I mentioned, and they really focus on directional questions and reflections. And so that's with my tip number 2 about chasing the change talk, It's really using your questions and framing your questions in a way to help predict what the client will say next in the direction of change. And then the last one that I really like is the use of mirroring. When you think of a mirror, you're just reflecting back what the patient is trying to say instead of inserting your point of view, instead of correcting them, instead of giving advice. And so the 3 tips that I mentioned today is that we're not fixers, we are helpers. The second is to guide the person to change talk. And the third is kind words go a long way. Rosengren has a wonderful MI workbook for those who just love to do MI stuff on the side and to do worksheets. I love it. I'm a nerd at heart. And they talk about how to rate your MI proficiency. So someone with advanced MI proficiency, or people here on the right-hand side, they move fluidly between the processes. So as I mentioned, the processes include engagement, focusing, evocation, and then planning. And they're constantly moving fluidly through those processes. They ask open-ended questions, but not just open-ended questions. They ask it in a directional manner that focuses on the strategic use of change talk. Spontaneous affirmations. The ratio of questions to reflections is 1 to 2. So you're saying more reflective statements than questions. And then finally, your reflections are deeper. They're not just the simple reflections. They're really focused on the complex reflections, focusing on repeating back the emotions, the values, the reasons for change. I wanted to end with a couple of last practical tips that easily elicit change talk. And these are rulers. So there's 2 different rulers that I'm going to emphasize. The first one is importance, and the second one is confidence. So oftentimes what I'll do at the end of the session is say, we've talked a lot about your weed use today. Now let me ask you a couple of questions at the end. So on a scale from 0 to 10, how important is it for you to change your blah? Where 0 is important and 10 is very important. So you sub in whatever the target behavior is, whether it's cannabis use, drinking, whatever it is. The idea here is if they say a number, it's not for you to interpret the number, it's for them to interpret the number. So oftentimes, like a patient will say 8, and you're like, 8, that's fantastic, and you judge the number that they say. Instead, they say 8. Say, tell me what an 8 means to you. Let them judge for themselves. 8, because I've come a long way. I'm really determined, blah, 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 blah. Let them say the change talk. Don't say it for them. So whenever you do this ruler, you always ask first, before interpreting the number, tell me what that number means to you, and then maybe ask a question to get them to talk more about change. So why a 4, not a 0? Always go for the drama. Don't ask about 1-point differences. Don't say why a 4 and not a 3, because it's cognitively hard to differentiate a 1-point difference versus a 4-point or more point difference. The second ruler is a confidence ruler. So same thing. How confident would you say you are that you could change if you needed to? Sometimes people don't think it's important for them to change their cannabis use, and actually oftentimes, but they rate their confidence very high. And this is your opportunity to reflect and to empower their self-efficacy. So if you were interested in changing, you could do it. Tell me more about that. And the research shows that when clients rate their confidence highly, it's associated with improved drinking and smoking outcomes. The last tip that I want to end here is the ask, offer, ask. I get it. We have the ethical responsibility to share information with our clients, especially if we're in a medical setting. If there's medical harm, if anything, we have the ethical responsibility. But we can do it in an MI way. And the way to do it is to sandwich the information with questions on either side. The most common question that I ask when I have to give information is to ask if it's okay. Would it be okay if I shared some information about blah, blah, blah with you? And then you offer them the information in a neutral manner and in a manageable chunk. Don't tell stories about the information that you're trying to say. And you have to sandwich it with a question after that. So ask, offer, ask. Provide the information that you need to provide it, but sandwich it with a question on either side. to keep it collaborative. Okay. So as I mentioned, I do a lot of research, and I am in the stage where I'm trying to better understand the transition after 12th grade for high school students, or even just for young adults. So if you work with high school students and you're up for having a quick chat, I would love to chat with you. Just about this transition period, about the resources they have after 12th grade, what patterns you're seeing in their substance use, what's new, what types of things do we need to understand, because we want to better understand ways to help this transition period. And so if you work with this age group, we'd love to talk with you, and we can pay you $50 as a small token of our appreciation. Email youthfocus@stanford.edu, and we'd love to have a quick conversation with you. Okay, I think this ends today. These are some resources that I encourage you to look up if you're interested. It includes the 4th edition of the MI book, as well as the MI workbook that we mentioned, or I mentioned earlier, and certainly if you have any questions, I'm happy to answer them. All right. I'm happy to answer any questions. If anybody has them, you can put it in the chat.
Great. Thank you so much, Dr. Osilla, for a great presentation. And I loved how interactive our group was today. That's wonderful. So while all of you are thinking about your questions, I want to remind you that we do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. And while you submit your questions, I have a few reminders to share. First, this webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Also, this webinar has been approved for 1 social work continuing education clock hour, 1 related McBAP credit hour, and 1 credit hour of CME. If you are requesting any of these continuing education credits, please fill out our evaluation form with your name and email address and follow all the instructions related to the specific type of credit you are requesting. The evaluation link will be shared in the chat shortly, and if you're unable to access that link for some reason, we will also be emailing that survey link to all of our webinar attendees later today. All right, so it looks like we do have 2 questions in the chat already. The first wants to know what to do with a client that from the beginning is unengaged and just keeps saying, I don't know.
What do we do with clients who are just not engaged and just say, I don't know? It happens, right? And I think in those situations, the engagement phase is super important. And what I often say, and this happens with adolescents, is I will say, this session might be a little bit different from what you've had in the past. What I really want to do is get to know you more and hear from you kind of what's on your mind. I know what's on your parents' mind. I know what's on your teachers' minds. But tell me more about you. Tell me what you're thinking and what your thoughts are. And then, you know, I do like the 7-second rule. Like, I'm quiet myself. And it's so darn uncomfortable. But it shows them that I'm not going to fill in the space. You know, and if they say, I don't know, well, okay, let's talk about something that you do want to talk about. It sounds like you don't want to talk about your cannabis use right now. Let's talk about something else. What do you like to do? How much fun, like, what do you do for fun? And again, really focus on the engagement where they want to go.
That is a great tip, finding something that they are willing to elaborate on so you can build that relationship. We had another question in the Q&A. How can you ask questions about family history in order to understand family history and experiences with close family having problems with alcohol or drugs?
So when we're doing assessment, MI is not the best fit for assessment because a lot of times we have a lot of set questions that we have to ask, and family history is part of that. But where I think the MI does come in when talking about family is asking questions that are open, like how does what might you say, like how does your family influence who you are today? We all have these stories as we grow older. How does your family fit into the story that you are experiencing now? And how do you want to rewrite that story for yourself? And so you might kind of blend in those types of questions when talking about the effects of family history. Oops, if that's helpful.
Great. And then one question I had for you is, can MI be used in groups as effectively as it can one-on-one? And are there any significant changes in techniques that you use when talking to a group?
Oh, that's a great question, Courtney. I'm going to put a website in the chat. I was fortunate enough before, I think it's this one, before coming to Stanford to work at the RAND Corporation, where we developed a group MI site for teens. So it's, there's the website in the chat. Group MI is very effective for teens. In fact, it is really fun because when you focus on the change talk, it almost switches the course of the trajectory of what the group is talking about. Because what one person says will be contagious. So if one person talks about how they don't want to stop their weed use, all the other teens or all the other participants will kind of jump on that same bandwagon. So as a facilitator, your use of MI is even more important to steer the course so that the flavor of the group is more oriented to change versus not change.
Great advice. And another question that came to mind, you mentioned the sandwich technique near the end of your presentation as a way to share information and facts with the client you're working with. Is there a certain type of information that is more well received by teens when you're working with them to get them elicit change? For example, is sharing a statistic more helpful, or is sharing a health impact more helpful?
That's a great question too. You know, I think it depends on the teen. Some teens are really jazzed by brain information. And so I kind of follow whatever the person is saying. So like if a teenager says something like, yeah, I heard something like that, it messes up with my brain or it messes up with XYZ, but I don't really believe it. Then I might say something like, oh, so you've heard that that cannabis can affect your brain. Would it be okay if I share some information with you about that? And then you launch into the information. So sometimes I pair the information with little bits of what they say to get their buy-in.
Great. Right. I don't think we have any more Q&As in the chat. So I will just share some reminders with everyone. Thank you so much again, Dr. Osilla. This was a wonderful presentation. And thank you all for being so interactive on attending our webinar today. We hope you found it both informative and interesting.
Thank you all for participating. I really appreciate it.
Yes. We would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. Please use the link in the chat to complete our feedback survey. And as a reminder, this webinar has been approved for 1 social work continuing education clock hour, 1 related McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out our evaluation form with your name and email address. If you're unable to access the feedback survey through the chat, the survey will also be emailed to all of our webinar attendees later today. For the next presentation in our series, we have Dr. Ronnie Lev, who will be presenting It's Just Pot, What's the Problem? That presentation will be on Monday, July 15th at noon Eastern Time. Dr. Lev's live presentation has also been approved for 1 social work credit hour, 1 McBAP hour, and 1 hour of CME. If you're not yet registered for any of our other webinars in this series, you can do so by using the link in the chat or visiting washtenaw.org/marijuana. We hope to see you at our next webinar, and thank you so much for your participation.